some important stuff. X-linked recessive, it's the most common one. They like to talk about the abnormality in the amount of dystrophin. Duchenne's is less than 3% of normal. Becker's is 3 to 10%. Becker's, as you all probably know, is like Duchenne's light, I guess. Increased CK levels, massively increased in Duchenne's and a little bit in Becker's. Clinically, the important things for us: scoliosis, calf pseudohypertrophy, Gower's sign, which is related to hip extensor weakness, toe walking and contractures. Just as a note, in any paediatric condition, spine, hips and feet are always involved, pretty much. You can always think of something that involves the spine, hip or feet. Most are wheelchair bound by age 10 and death by age 20. Scoliosis has its own separate category because it's the most important part of it. Rapidly progressive, and it's different to your normal idiopathics, where the trend or the thought is that you should treat it earlier. Kind of paradoxically, to improve their pulmonary function, and one of the main risks of the surgery is because their pulmonary function is quite bad to begin with. And malignant hypothermia I've chucked in there just so that you don't forget it. Charcot-Marie-Tooth.
The other thing you should have is steroid treatment. Steroid treatment is very effective in preventing the problems that you just put up there.
CMT, recategorized as hereditary motor sensory neuropathies. Autosomal dominant is the most common, the one that we're interested in. Chromosome 17. Again, scoliosis, hip dysplasia, cadaverous feet. Inverted champagne bottle legs is one of the classic features that they talk about. And it's sort of its own big topic, and I think you'd really need to look into Charcot-Marie-Tooth as its own topic, but generally the thought is that you get tibialis anterior and peroneus brevis weakness more so than with preserved tib post and peroneus longus, and you get intrinsic muscle weight wasting, and as we've just heard, that goes towards causing the cadaverous feet that we always see. Spinal muscular atrophy, autosomal recessive, it's a loss of anterior horn cells. You get a symmetrical paresis with the lower extremity and the proximal muscles being more involved. Simple little classification scheme to remember, and that's from the SMA collaboration, if anyone's interested. Orthopedic conditions, scoliosis, hip dislocation, lower limb contractures. That's a big recurring message there. Again, with most of these neuromuscular conditions, the scoliosis tends to be more severe and tends to be more progressive. Congenital muscular dystrophy is a heterogeneous group of autosomal recessive disorders. You get hypotonia, weakness and contractures. There are 4 categories. If you can remember them, that's probably pretty good, and that's about all I knew about. No. Myotonic dystrophy, autosomal dominant. The definition of myotonia is an inability to relax after contracting. The important thing, as Epi said, I think, in this condition is the widespread organ system involvement. Feet, hip, contractures, and then the cataracts, endocrinopathies, cardiac defects, and intellectual disability they also get. And the last one I've got here is facioscapulohumeral. For some reason, it's an examiner's favourite. It's autosomal dominant. They get facial, scapular, and humeral abnormalities, but the facial ones, they can't whistle, is what they talk about. They get shoulder girdle weakness and lateral scapular winging. They have a normal CK, which distinguishes it from the other myopathies, and I put scapulothoracic fusion there because that's about the only thing with these.
One of the reasons it comes up more often